So for the last bioskills lab that we have here, we have the Mazor X Stealth Edition robot. It's one of the main robots at Cedars that I use. Today we've been talking a lot about what else do we want with robotics besides stay and hold screw delivery. And Medtronic just came out with the 5.1 new software upgrade, kind of like how iPhones get upgraded. The software is something that Medtronic continually focuses on and is trying to achieve a lot of the goals that we are asking them that we want. The 5.1 offers the 5.1 software offers many new upgrades, including faster processing, pre-planned screw trajectories, or it drops screws more accurately to where you need it to go. There's a lot of registration efficiencies that are software-based, and ultimately their newest highlight, or their biggest highlight, is this facet decortication that I want to show you, because I think it has big implications into the whole next-gen decortication model, decortication and laminectomy decompression model. So today what we're going to do is I have the whole team, but I have Brian Anderson. He's one of the SSF fellows. He's helped me expose and kind of hasn't really used the robot, so kind of another example of how you can incorporate trainees immediately into your workflow. I got Matt and Cole from Medtronic helping me as well, and I thank the whole team. Also wanted to always thank the Seattle Science Foundation, all the co-directors for getting me involved. So let me take you to the software screen, because Medtronic is focusing not only on screw insertion, and this robotic system is focusing on software. And their software is, I think, what is far superior to the other models that I've seen so far. The user interface, obviously, is very elegant, easy to use. But the newest, what you'll see here on this screen, can you zoom on that a little bit more? Is these two new bullets that you're seeing on the actual imaging. So what you see are pedicle screws that you see on any software system with robotic technology. But you have these new little bullets, this yellow bullet here that I'm highlighting with the red little caret or red little dot area in front of it. And this is the predetermined trajectory that you can design or place to where you want to decorticate the facet. So if I click on it and I drag it around, I can move this anywhere I want depending on where I want to decorticate the overlying bone. So this one, I lie right over the facet joint on the axial. I'm going to move that a little bit over and down, and the red zone tells you where, as far as the tip of the drill will go, so you don't want that obviously to go into the spinal canal or the lateral recess, but the drill will come down this trajectory that you determine in order to decorticate the bone. On the sagittal screen, as we scroll through it, it'll also show the sagittal plane of that facet joint, and we're targeting it right at the middle section of the facet joint. And so again, we can click and drag the original plan, move it around depending on where exactly the facet is located. And in effect, what we're doing here is we're telling the robot this is the area that we want to decorticate or remove bone. What's an added benefit of this facet decortication is we can add multiple bullets to the image. So here's me adding a second bullet, a second yellow bullet, and same trajectory, but on the sagittal, I can move it below or above, and I can set it there to decorticate the overlying superior portion of that sagittal facet. I can add another bullet, a third bullet, and again, add that third bullet, or is it two or three? Oh yeah, the third bullet. And we can bring that over to the sagittal. We would bring it over there. I'm going to angle it again over the facet joint, but then bring that third bullet to the bottom of the facet. So here we now have a system The only system on the market that is able to, that you can determine or you can dictate exactly where you want the bone removed, and eventually the robot will get to that area and provide the drill in order to decorticate. So Medtronic currently is calling it facet decortication, which is exactly what it is. But as all of you in the room and everyone online can understand, is the easy next jump from that is decompression or removal of additional bone, not necessarily associated with the facet. But baby steps. These are evolutionary changes for something that we're trying to get to that's revolutionary. So again, to answer a little bit of today's what more can the robot do, this is the next generation of what's here today. And 5.1, by the way, is available in market. It's in centers right now, and they're rolling it out across the country. So that's the software stuff. So we'll head over back to the cadaver. And I think when we're talking about can we see the actual cadaver here? As we're looking at the actual cadaver, when you're doing percutaneous MIS incisions, which are these guys over here, trying to decorticate that through these small incisions is oftentimes not an easy feat, or it's a difficult feat because you don't really know where the facet joint is. Usually what I do is I put my finger down there in this tight little hole, and then I just drill whatever I can that feels like bone. This is actually different where it's targeted. We know exactly how deep to penetrate, and Brian's going to demonstrate through a percutaneous incision how we're able to get that facet decortication. So we'll go on to the right side. That's the left side. Coming over. Brian, I'm going to hand you this. Okay, you drop it down just a little bit. Okay, and then we're going to move that over there. So then what Brian looks at first is that as we line up, that green line is going straight through our preoperative plan. Pull that out. This then represents the drill, the facet decortication drill. It's a acorn drill bit. It's circumferential. It also has a cutting flute to the tip of it. So basically remember that bullet-shaped trajectory that we already pre-planned. It's going to follow through by going straight down our robotic end effector into the actual facet. And then if you look at the actual screen, let me pull this screen over here so you can maybe see it. Brian, it's going to take some fancy arm movement. Can you zoom on that anymore? Is that right? So then as Brian drifts it all the way down, we're going to turn on that drill. And so what he's doing now is he's actually drilling that deep facet out. Then you're going to pull it straight out. Okay. Ooh, got a little muscle tendon here. And that becomes the facet decortication of the bony area. Associated with that, once you decorticate that overall facet, we have a facet bone grafting gun, and that goes again through the same channel. And it's almost like a caulking gun, so you squeeze, it delivers about 1.5 cc's of bone graft, and that's usually enough to pull it out. So facet decortication done in a couple seconds seems pretty not that, it doesn't seem like it seems to move the needle that much, but in its own right, the fact that the end effector is taking you to a bone area, a bone channel area that you want to remove and that you want to decorticate out, and eventually the steps that the minor steps it'll take to actually decompress seems pretty encouraging. So then after that decortication, the traditional workflow is to actually pre-drill your pilot screw holes, then facet decorticate, then go back to your actual screw insertion. So we're going to go back to putting in the screws on his side. And so the first one will be the right side L2. Okay, Okay, so again, you're looking at that screen, and again, checking that the overall trajectory is exactly the plan that you picked. This is the Midas drill that goes in next. He goes down, and we're going to turn it on. Ready? A little bit off the bone first, then drop it all the way down. Good. It should go down to a depth of 30 millimeters. Pull that out. Next comes the tap. Okay, so then we'll just turn this. This has to be turned on, so yep. Go ahead. A little bit past the pedicle, yep. Reverse, reverse, and then pull it straight out. And then finally the screw insertion, you can pull that cannula out. Okay, good. Is this all the way in? There we go. It's all about making Brian look good, by the way. Okay, yep. And then remember your arm has to go there so avoid, yep. And then as you look at the screen, his hand's in the way, but it's slowly kind of advancing the tract down the pathway that we want it to go down to. Good. And Brian, if you can just move your hands out of the way for a hot second. Let's leave that there. Yep. And so if you zoom in on that again, screw goes in the trajectory that is already pre-planned. Okay, then we repeat that for the next level. Do you have a 10 blade? 10 blade? 10 blade? I think it's this. All right, hold on. Actually, our incisions were a little bit too small, it looks like.
It's good there.
Good.
Lines up.
Okay. Midas, make sure it lines up. Okay, a little bit off the bone. 30 millimeters. There's a hard stop here, so you can't really advance it beyond that. Tap. So you can, there we go. Okay, all the way through, past the pedicle. Good, pull out. Okay, good, and then we'll pop that off. Give him the screw.
Hey, Terry.
Yeah.
So I don't remember, you weren't doing MIS T-lifts in fellowship or practice. So was robotics your entry into MIS T-lifts?
So the question is, I wasn't doing it in fellowship, and did robots help me enable that that technology for my practice?
Yeah.
It was actually, you know what? It was actually nav first. I was really fast at just doing open T-lifts like many of my colleagues. So again, one step back to get navigation involved. And it was just one of those things where that navigated Wiltse incision, I do MIS, I would say mini open technically, because they're small 1.5-inch incisions on either side of the paramedian midline. But navigation was kind of finicky. The retractors weren't quite right. And it actually took the robot for me to jump to making it more regular. I like the fact that it's the mental kind of anguish of trying to get each screw in appropriately. The retractors for mini open T-lifts are so much better these days. They're screw-based instead of these small little tubular retractors. And I think it was a combination of advancement in dilators and the robot that helped me. But anytime I do MIS T-lifts now, I use the robot for my T-lifts. And so to answer that, it wasn't a direct cause, but it certainly is a reason why I continue to use it. And I think from that standpoint, it definitely, and Manista would probably agree with me, it definitely, I think, makes robotic T-lifts make it easier than open or nav, at least in our hands. So if we jump over to the other side, and what I'm showing you, again, here's an example of an MIS T-lift kind of approach. And so, again, mini open incision, made it a little bigger. We have our two Voyager screws in with this screw-based retractor system. But again, the highlight of this BioSkills lab is not how to do MIS T-lifts with robot, but essentially it's to the added benefit of that facet decortication. And so if we go to the original screen, and show them the right-sided facet decortication. Okay, so on the right side, and that would be the blue side, right there, we've already marked out where exactly we want our facet to be decorticated on the axial, on the sagittal, and we've selected the trajectory that we want. Then we go back to the navigated portion and we upload that into the robotic system. Is that good? No, the reference frame's right in the way. How about that? A little bit better? Okay, good. And then again, it's the same process, but now we can do the drop-down camera view. And so we bring the robot to the ideal trajectory, and just kind of showing you again the orientation of this dilator to the screw to where the facet should be. The dilator goes. We check on the screen that it works or it's in line with where we're headed. And this is more that kind of show them that. Again, lining up exactly with the shot of the decorticated facet region of bony removal that you want. And then ultimately with the acorn drill bit, we're going to slide this down the cannula. I'm going to lift the cannula up so you can kind of see what exactly we're doing, but that's the cannula right down there, and that's going to drill the facet joint right down the middle, and so we do that. Normally the cannula goes all the way down to hold it in place. Okay. Set to the depth that we set. And so the cannula prevents you, the robotic end effector prevents you from going any deeper than you need to go. And again, if we had a second one, we can punch in a second hole or a third hole, depending on where you want. The software also tells you that you're too close to the screw and that particular facet trajectory won't work. So it kind of guides you exactly where you need to be safe. It also tells you that you're heading into the canal with that red kind of carrot or the red buffer zone in the front of the bullet that tells you that you're not in a place where you want, or you're too deep. I wish we were, actually I think we can, but you get really down into it and you can kind of see that it's a really nice facet decortication all the way deep inside the bone. And it's a good, how long did we make that bullet? We made that bullet, I think, almost 22 centimeters deep. This again is the bone grafting material, and as it's a caulking gun, and as we squeeze little pieces of bone graft, okay, yeah, no. It's, yep, you see right there, it's coming out as I squeeze it, okay. And so if we go back to the main camera up above, we slide that right in. I'm going to pull the cannula back so you see that that's the actual bone graft delivery. It fits right into the plugged hole. And then as we squeeze one, squeeze two, it fills the bone channel up, and then boom, we're out. There's your bone graft. You put whatever FDA-approved bone grafting material goes into that facet. So hopefully that explains things. Again, another evolution in the software portion of robotics. The facet decortication on paper or on face value, probably not exciting, but as our imaginations start to roam and you realize, I know Brian, as soon as I told him that, and his imagination, he's like, wait, isn't this decompression, isn't this removal of lamina? And I'm like, yes, at some point we'll be able to, you can imagine we can direct exactly where we want our area of decompression to go, remove the bone, and that's the next step of where Medtronic is headed. So thanks a lot, guys. Any questions?
Terry, great talk, and great demo. And I want to ask you a little bit of a question. You take longer to do it here than you do in the operating room.
Well, you know.
You know, I go have a cup of coffee and you put 4 screws in, and you're done waiting for me when I come back. So,
Some days
can
it's
you
better.
explain why you're slower here than you are in the operating room? Sorry to put it that way, but Danielle says, ask him a question. I say, well, here's the first one that comes to mind. And
I usually don't talk as much. B, I didn't just have fried chicken for lunch. But no, I mean, you know, it's I didn't think I was that slow. I mean, I don't know if you're trying to knock the fellow. I think he did a fantastic job. But, you know, it's one of those things that even in this kind of short, I mean, this was less than 15 minutes, and we already got 2 screws in, 2 facet decortications, and we had another 2 screws. So we've already have our instrumentation and fusion section of this done in 30 minutes or so. So
I have a quick question, it's Andy. So when I do my T-lifts, it's not uncommon that I'll want to take out the facets to loosen it up before I do the reduction. How would you change your flow? You know, I know Danielle's got the flow. I'm trying to get the flow. How would you change your process so that you have a smooth ability to do that?
are you talking about, do you usually take out both facets?
If I'm doing a grade 2, I'll frequently take out both so that I can have it freely mobile, or at least get enough of the cartilage out so it'll freely move.
Yeah, I don't think your or my workflow would change too much. This facet decortication system is for, I think it's best served for obvious contralateral facet, not ipsilateral facet where you're going to put the T-lift graft down. So I don't think this is really, unless you wanted some kind of percutaneous, just drill the entire facet out. I imagine you can put a bunch of bullets in and just continue to fire the drill down and follow the facet and punch holes to the point where it just disintegrates the entire facet in its entirety. But I don't think that would change, my workflow would change as much. You know, a lot of this is screws in first, right? And then knock the facets out, and then do your T-lift, and then get the reduction. Sometimes if you have headless screws, you can kind of put the screw shanks in first. This particular retractor system is screw-based. Before I used to put guide wires and just deflect them down, do my T-lift, and then put the screws in. But you can actually put all 4 screws in first and kind of affect your decompression, your inner body, and your deformity correction all in one. Any other questions?
well, great demo, Terry.
All right. Thanks, Danielle. Thanks, Pat. Thanks, guys. Nice job, man.
Good job.
Yep.
All right, that's the end of